Good evening. On behalf of the American Society of Shoulder and Elbow Surgeons, I am Dr. Ranjan Gupta and Gus Mazaka as education chairs. We are hosting tonight's virtual fellows conference under the guise and supervision and auspices of Dr. Bill Levine, our president. Tonight's session is infected shoulder arthroplasty with a neurologic deficit. The speakers tonight are Andrew Jawa, Jonathan Levy, Eric Ricchetti, and Adam Seidl. Dr. Ricchetti is the moderator and will be leading us on. And with that, I turn over the podium to Eric. And as usual, Gus and I will be monitoring the chat room and feeding you questions so the rest of the panelists don't need to look at them.
Thank you, Ranjan and Gus. It's great to have the opportunity to present. I think we've got some interesting cases that will get at the management of both these complications individually, and then also when seen together, how this changes decision making. So I just want to acknowledge DJO as our sponsor for this series, and our disclosures are on the Academy website. So just a quick overview of these complications. You know, we know that shoulder PGI is a diagnostic and therapeutic challenge due to the low virulence of the commonly cultured organisms that we see. P. acnes is the most commonly cultured organism in revision shoulder arthroplasty. It's been identified more recently as C. acnes, and then coag-negative staph is typically the next most commonly cultured bug. And instead of seeing this obviously infected shoulder that you can see on the right, more commonly we have this subtle non-specific clinical picture, often with a delayed presentation that can make diagnosis and management more challenging. And then with regard to nerve complications, fortunately these are rare after shoulder arthroplasty. The literature suggests a rate of 1 to 4%, but there is a higher rate across studies with reverse shoulder arthroplasty. These typically are plexus stretch injuries, but you can see severe injuries after shoulder arthroplasty. And again, diagnosis and management can be challenging. There can be very obvious severe injuries, but probably more commonly, we see underreported injuries that may be unrecognized or subclinical. So with that, I'm going to get into our cases. And our first case is a 72-year-old male who presents 4 years after reverse shoulder arthroplasty for a massive cuff tear. He has no history of prior surgery, has done well after surgery, and currently still reports minimal pain, but notes over the last 6-month period developing a draining area along his incision that you can see on this video on the right. And John, if you want to give us a little more background information, any precipitating event to this area of drainage?
No, to be honest, you know, he came up, he lives down in the Keys. It's a decent drive for people to come up from the Keys, and they tend to be pretty content down there. And he just got sick. He got sick of changing his dressing, and he was really more concerned with the drainage coming out of his shoulder than anything else. He was very satisfied with his motion and his function. You know, and I think that makes this not a diagnostic problem as much as a clinical problem of what you do.
So he had some blood work drawn and actually had a normal ESR and CRP. Adam, what do you think of his x-rays, and at this point, any further workup you would do?
I mean, I think this is infected. I mean, I think he has a draining sinus around a reverse shoulder replacement. His x-rays, obviously, you're starting to think about what do you do with this, and you see he has a well-fixed humeral component with cement around it, which isn't great, but everything, again, looks well-fixed, it looks well-placed, and he has good function. So I'm starting to think about what the next step is. How do I treat this? I don't, you know, you could consider getting an aspiration, but I think you're going to need to do something with this guy.
Anyone else do an aspiration at this point?
Yeah, Eric, I'd probably do an aspiration. I think it would help in my decision making if it came out MRSA, which it probably won't be because MRSA is a little bit more aggressive than this, or MSSA. I may consider a 2-stage reconstruction as opposed to a more indolent bacteria like C. acnes, which I might consider a 1-stage.
So Andy, if you're going to do a 2-stage, like you're thinking, let's say this is a nasty bug, which yeah, I agree with you. I mean, I know this case, but I still wouldn't think of that guy. I didn't think he had a nasty bug when he came in.
Yeah.
If you do a 2-stage reconstruction, what do you think the chances of him ever getting the same function he has?
Definitely decrease. You know, when I do 2-stage reconstructions, I feel It's more scarred up the second time you go there. Their function is less good. They're a little bit more painful. My concern though is if you do a one-stage reconstruction, you may not get rid of the organism. You know, Garrett Goose did a really good review, meta-analysis that just came out June 17th. And I was looking at it and there's a treatment bias. So the ones that are treated with two-stage have about 10% reinfection rate, but there is a higher tendency for them to be MRSA or MSSA. While the one-stage, which had about a 6% reinfection rate, they were more C. acnes. So, you know, it's confounded data, but it would push me in a more virulent organism to do two-stage for that reason.
So, you know, we've talked a little bit about surgical planning. Adam, you were mentioning a little bit about that. Any more preoperative imaging you'd want before deciding on surgery?
I mean, I think it depends on what I'm going to do. I actually would most likely treat this in a two-stage. So I don't think I need any additional imaging for that. You know, I'm planning on removing everything, removing the cement and placing a spacer. I don't think I need a CT scan or any additional imaging for that.
John, how about you?
You know, I get a CT scan on every case. In this case, I think there's just, you know, a tip that you see that's really implant specific. If you look at the center screw and you look at the posterior screw, those are supposed to be parallel because they're non-variable angle locking screws, right? So if you see one going off at an angle like that, there's a real high chance that the head is stripped because it's cross-threaded. So if you're ever revising an implant that has a fixed angled screws and you see them go off axis, that means they were put in at a slight angle. The heads often get cross-threaded. So, you know, in addition to your normal, how you plan this, where you're going to get out, make sure you have an easy out set to get a screw removal tray. Just a quick tip. But from an imaging standpoint, maybe a CAT scan helps you see that. I get a CAT scan. I don't get tag white blood cell scans or bone scans unless I'm trying to do I think this is loose or not? This thing doesn't look loose. I don't see any value in doing a tag white blood cell scan. The data on that's pretty crappy actually. So I don't do any additional. I get a CAT scan more for planning, not to help me with the workup of infection.
Great. So yeah, in this case, why don't you walk us through this imaging? So you actually got an MRI in this case, and what was the decision making for getting this?
No, this is not my patient. He had it reversed done elsewhere.
Oh,
and
sorry.
Despite an implant that I'm used to using, he came to me for final treatment with this MRI saying,
got it.
You know, I got this cyst. I would not normally have gotten an MRI, but because he had it, it actually shows a pretty cool finding, just helps, you know, clarify that there's more than just, you know, more beneath the skin.
Does anyone routinely get MRIs? I mean, our institution doesn't have metal artifact reduction for MRIs, so I never routinely get MRIs with implants. Does anyone else have that capability?
We have that, but I find them not to be amazingly helpful.
Same.
Yeah, I agree. This is a great image, though, to see the collection. And then we have CAT scan now.
Yeah, that one I ordered.
So, you know, if you again look at this CAT scan, I think it brings up the points we discussed in terms of this appears to be
Eric, could you tell the
fixed.
group could you put a pointer over and tell people what you're seeing?
Yeah, sorry about that. So if we go back to the MRI, so I think on the, sorry. So I think you can see the collection here in front on the MRI, which is nice, and then also around the implant. And then same here, you can see the big collection out here laterally as you scroll through the MRI right there. And then on the CAT scan, you know, looking at the base plate, I think this looks well fixed, and same with the humeral stem and the cement mantle, similar to what people were saying on the x-rays. So in summary, we have this 72-year-old male with what we think is a chronic PJI and a draining wound with a well-fixed implant. We have our different treatment options here. in terms of suppressive antibiotics and 1 and 2 stage revision, and within 1 stage revision, both complete and partial revision. Why don't we go through the group in terms of what they would do, and then John, maybe you could give your option last and present what you did. Andy, what about you?
Yeah, I mean, this is really interesting and a great case, because I think there's value in every single one of these. I mean, I would consider suppressive antibiotics if this guy was infirm, which it sounds like he's not. As I mentioned, I would consider 2-stage if I came across pus or I found it was a bad organism. If I knew it was P. acnes, I'd probably do a single-stage revision. And in the last one, I find the last one really interesting because, you know, if the base plate, getting the base plate out is prohibitive and you destroy the glenoid, I actually see some value in potentially changing out modular parts. I think the stem in this case will come out pretty easily. But if you had like a long ingrown post, I would consider doing some modular exchange. But this particular prosthesis, I think, can come out relatively easily. I'd probably do a 2-stage if I found pus, 1 stage if it looked okay.
Adam, what about you?
Yeah, I mean, I honestly have never done a single stage and it's someone with a draining sinus. And to me, that is just a little different. But I guess if it was a P. acnes, if you had an aspiration and it was P. acnes, you can consider a single stage, but I would do a complete revision. I mean, this has been draining for 6 months, so this is more chronic. But again, I would err on doing a 2-stage revision. The question is what do you do? I mean, I think with a 2-stage revision, obviously you're going to remove all that cement. I don't know for these other, obviously for the modular, you don't have to deal with that. But for the option number 3, single stage complete revision, John, what would you do with all that cement in the humerus?
You want okay, I'm ready for it. Yeah, so I think you guys, for me, this guy's function is so good preoperatively. And I'm fairly confident that if I do a 2-stage revision, I don't think I'd get him back to that same degree. And I think if I do a single stage and do an aggressive debridement, then I got my best shot. So to answer your question, getting the cement out, you know, this particular stem comes out pretty easily, but it's got a polished, you know, it's not polished, but it often leaves the cement. And so in terms of a surgical tip and a surgical technique, I take a 6.5 cannulated screw set and I will under fluoro drive the guide wire past the cement all the way through the plug, although this probably has like a gummy bear type plug. It probably, there's no plug there anyways. But I get past the end of the cement mantle, and then I drill it, and then I take the tap for the screw and go in 1 centimeter increments and put a vice grip attached to it and bang it out. And so I'm taking out segments of cement as I walk my way down all the way to the tip and take the whole thing out. And it doesn't work every time, but I think I did it in this case and it worked pretty well, because it can be a bit of a pain to get all the cement. And if the cement goes down to the elbow, there's a point in which you give up. And, you know, there's a point where it's just not worth destroying the humerus in order to just get out all the cement. If I can get it all out, I will spend an extra half hour, 45 minutes chipping away and getting the thing out. We can talk about windows and things like that as other alternative methods to get there. But in this case, that's not what I did. I did intramedullary removal of cement. And I do that more as a rule than an exception. And then when I do my single stage revisions, I treat them as 2 separate surgeries. And this is what I mean by that. So I'll do an aggressive debridement, you know, take out all the implants, all the cement if I can. Then I irrigate with dilute betadine, dilute peroxide, clean scrub. When I'm done with an aggressive debridement, I change everything, meaning, you know, I don't close the wound, but I put on new drapes. I change my scrubs. Not my scrubs. I change my gowns. We use all fresh instruments and literally bring in an entire new set. So it's truly a fresh case. It's just being done at the same time. So I still put a patient on 6 weeks of IV antibiotics and some oral suppression if the ID team wants it. But that's my version of a single stage revision. I know I'm not the only one that does it this way, but I think that is a distinction when you're doing a single stage, to do it as literally 2 separate cases within the same operative setting.
Yeah, those are great points to make, John. I think, you know, a single stage, you want to make sure you do everything you do and do a complete debridement so that you're treating the infection as effectively as possible. And I agree, taking the cement out can be the biggest challenge, and that technique you have, I think, is a great technique to use. You know, I would say for myself, I would tend to err on two-stage in this setting too, because of the chronic draining sinus tract, but I do use some intraoperative decision-making, like Andy mentioned, in terms of is there gross purulence, are there positive frozen sections. So why don't we move on to what was done. So intraoperatively, 6 samples were taken, and you can see that 2 out of the 6 cultures grew C. acnes. Frozen sections were taken in this case and were positive, and there was gross purulence, and like we thought, the implants were well fixed. Just before we get to some of the additional details of the surgery, I did want to highlight some of the work that's been done recently at the International Consensus meeting, which was held a couple summers ago, to help develop consensus diagnostic criteria for PGI of the shoulder, which had not previously existed. We had previously used the MSIS criteria that had been developed for hip and knee, so this meeting now established criteria for the shoulder. And 2 different categories were created from this consensus criteria: a definite infection category for overtly virulent cases, and then a scoring system was created that created a scoring scale based on likelihood of infection for those cases that didn't meet criteria for definite infection. And you can see the criteria for a definite infection here, which is the presence of 1 or more of these criteria, which is a sinus tract communicating with the prosthesis, gross intra-articular purulence, or at least 2 positive cultures of a virulent organism. In this case, we're presenting here 2 of these 3 criteria present, so this would be considered a definite infection. And then you can see now in the scoring system that if the criteria for definite infection were not met, we have this minor criteria shown on the right with different weighted scores that, when added up in a particular case, give you these different categories of probable, possible, or unlikely to be PGI. And you can see if there's a score of at least 6 in an organism, it's probable PGI. If there's no organism but at least 6, a possible PGI. And then if you get lower scores with an organism, possible PGI. If all cultures are negative, it'd be considered unlikely to be PGI. And an important point with this new criteria is appropriate intraoperative tissue culturing sampling technique. The ICM meeting also recommended taking at least 5 deep tissue specimens at revision surgery when getting your cultures. And if we apply this criteria in the current case, if we assume in the current case that there was no sinus tract or purulence, this case had 2 positive cultures of a non-virulent organism. So it gets a point for the first positive culture, 3 points for the second positive culture, and then another 3 points for the positive frozen section. So even in the absence of the sinus tract and gross purulence, this would still be considered a probable PGI. So John, how about you walk us through what you did specifically in this case? You can see the post-op x-rays here. You know, in particular, you changed your glenosphere size here, have a little different stem. So I was wondering if you can comment on your intraoperative decision-making for implant sizing.
So in this case, you can see on the, you know, trying to get the cement out, you often will perf on the side. So you can see there's a tiny little perf you can see in the lateral cortex. So if you have a perf and you're cementing, you just got to make sure you get all the cement out, because if that perf is on the wrong end, you get yourself in, you know, radial nerve can get can get close pretty fast. But my experience is when you do these huge aggressive debridements of an infected reverse, they are a lot more unstable. So I went up on the glenosphere to a much larger glenosphere that creates inherent stability. I believe that was a 44, which is the largest glenosphere that is in this system, and it's lateralized 6 millimeters center rotation lateralization. So it gives you, it really fills the volume quite well. The technique that I use whenever I cement a stem is to try to hybrid the cement. So the cement's mostly distal, and I allow the ingrowth. There's a porous ingrowth metal at the surface along the rim of the shell. So if I can get sort of bone ingrowth up top and cement the fixation distally, that's kind of my choice whenever I cement. So that is the technique I used here. And the only reason it's a different stem is that's the stem I typically use now. I like the ingrowth potential on the shell better than the previous version that was there. But I do think that the message here in my mind is when you're doing these big revisions, if you're doing huge aggressive resections like you need to do when you're doing infection debridements, you're typically going to need to soft tissue balance with instability type implants, which are typically larger spheres.
Yeah, I
John,
agree.
one quick question for you. When you took out the base plate, was there a cavitary defect in the glenoid that you had to address? And how did you put in the new base plate?
So when you're revising this base plate, here's another surgical tip that I use quite often. So if you actually look at the X-ray on the left, and you imagine Navisor's portal, right? Navisor's portal, which goes just on sort of the medial aspect of the acromion, between the acromion and the clavicle. If you drop let's say a K-wire or even a spinal needle down, it almost lines up perfectly with the back of the implant. And so if you make literally a percutaneous portal and you just drop in an osteotome or something perpendicular, you got a straight shot down the back side of that implant. And so you can disrupt the bone prosthetic interface. And bone fails in torsion. So this is once you get the peripheral screws out, and you might have to use an easy out to get some of those peripheral screws if they're cross-threaded. But once you get down to the base plate, if you unscrew that base plate, the bone fails in torsion pretty quickly. And once you disrupt most of that bone prosthetic interface from a flexible osteotome from behind, this thing comes out pretty routinely, easily, without huge cavitary defects.
Thank you for the pearl.
Actually, John, you taught me this trick. You taught me that last trick, but also using portals where you can put tamp underneath the coracoid or around the conjoined tendon to get your angle to hit it laterally. So using portals and different ways of thinking to try and get implants out. That's been great for me.
Now, John, you mentioned postoperative antibiotics. I think you said you did 6 weeks of IV antibiotics and a period of orals. Andy and Adam, anything differently you do in terms of postoperative antibiotics? Is that similar treatment in your guys' hands, 6 weeks of IV antibiotics and then maybe some period of orals?
Yeah, for me, the 6 weeks is pretty standard, and I really just defer to our infectious disease team here. But the oral, I leave up to them. You know, this is someone that I think our ID team here, knowing them well now, they may consider kind of long-term oral suppressive antibiotics for this guy.
Does anyone have a set amount of time they put people on orals for, or is it sort of gestalt?
No, I don't think we have any good data that kind of guides us. It's all paranoia and gestalt, and I think so long people aren't having negative side effects of the antibiotics, we like suppression for a long time. I mean, we use doxycycline and minocycline, and I've seen a lot of people come back with nasty sunburns from doxycycline, and I've seen a few cases of black bone disease from chronic minocycline when you're revising their other side and they have these black shoulders. It's quite impressive. Just a couple points, because I know this is really a fellow education course, and two things when you're starting practice that relate to this type of stuff. And the first is get to know your pathologist. It sounds crazy, but when you call for a frozen section and they call you back and they say, there is a acute on chronic granulation and inflammation, and then you're like, well, I just want to know how many white blood cells in a high power field, and they're like, what? So get to know your pathologist, find out which ones are comfortable doing orthopedic pathology, and the same thing on the ID side. Wherever you go, just make sure you get to know an ID doctor that you trust. If you have access to an orthopedic specific ID doctor, that's even better, but not everybody does. And just get to know your ID doctors and have a really good relationship. We're often dumping all the decision making onto them, but get involved in the decision making with them and participate. Just 2 tips.
Hey, John, can I ask you real quick, what was your thought process for getting frozen section in this case? Because, I mean, it seems to me with purulence and it seems to me like you kind of had your mindset you were going to do a single stage in this guy. What did you think that would add to this?
Yeah, at the time, that was what I did. And now I think it depends on the pathologist that I have. And, I don't use it routinely, to be honest. I think you're right. This is by definition, infection. I don't think the frozen section would help me unless I really wanted to kind of, calculate with our new criteria, whether, add a couple extra points to the game here. This one's not controversial in my mind. It's only controversial because he's got such great range of motion and function. And so maybe at the time I wanted to make sure for sure it was infected. Maybe the pus wasn't really pus. I don't know. I probably wouldn't have gotten. Now today, if I did this case, I probably wouldn't have gotten a frozen.
Yeah, I just asked because I used to do frozen sections a lot more, and I've just almost completely gotten away from that just because of some of the issues that you mentioned as far as timing in the OR. And we have a new pathologist who's there every, it's a different one every day. So it just got a little frustrating. Right. So.
Yeah, I agree. I mean, I think the frozen sections, if you don't have a good pathologist, can not always be useful. I tend to use them in cases where it could be borderline in terms of whether I'm going to do a 1 or 2 stage because of maybe 1 or 2 positive results, and I'm using it to tip me one way or the other. So just very briefly reviewing the literature, there's, Andy hinted at this, there's a lot of heterogeneity in the literature, but this study by Jason Su and Rick Mattson is probably the best study in terms of looking at a uniform cohort of C. acnes patients. And they compared patients with C. acnes infections to a control group undergoing revision. This cohort's a little different in that these cases did not have any overt signs like this case we just presented, but you can see here when they compared the cases that had at least 2 positive C. acnes cultures to control revision cases, there was no difference in outcome when doing a 1-stage revision. So I think this is a good study speaking to the fact that indolent infections can be treated with 1-stage revisions. And then Andy hinted at this. This is a slightly earlier systematic review where you can see that there's similar eradication rates in 1- and 2-stage revision, particularly much better than some of the non-resection techniques, but there's a lot of heterogeneity in the literature in terms of the bacteria that's treated with each of these, so it can be somewhat difficult to interpret. Now, just to end this case, since we're trying to talk about combined complications, I'm gonna add a little clinical twist to this scenario. So a lot of us talked about doing a 2-stage revision in this case, so I wanna now present this case as a 2-stage revision where we go in and do an explant. And after our explant anabolic spacer placement, this patient now presents with a significant axillary nerve injury. And my question, if we have this scenario now where we've now treating this infection still, but in 2 stages and now have a nerve injury to deal with, how is this going to change our management? Both in terms of antibiotic treatment of the nerve injury, and then also our timing of reimplantation. So Andy, why don't you give us some thoughts on this now when we are dealt with this more complex decision-making?
Yeah, I think the major thing it would do for me is I would wait longer to see if the axillary nerve recovered. We can keep Prostalax in for a long time, and I wrote this up with JP a long time ago that people have Prostalax for years and they can do okay with it. So I'd wait till it returned because I'd worry about instability. You can definitely do a reverse in the setting of the axillary nerve injury, but in this case, there's no rush. I'm not sure this would affect my antibiotics at all, though.
How about you talk about until the nerve recovers? What's your definition of that? Does it have to be 100%, or is there some level that you consider acceptable for reimplantation?
Yeah, I think you need to see some firing 4 out of 5, strength in the deltoid. Sensation's not enough. You need to have something that can keep the reverse stable.
Adam, would you do anything like an EMG to help with that decision-making process?
I probably would. I also think it really depends on my level of concern for a significant injury. I mean, when I'm explanting these or doing any revision, I try to develop the planes and palpate the axillary nerve just as I would in a primary. So if I was 100% certain that the axillary nerve was intact, I had a good palpation, I had a good tug test, and I'd probably, I would still wait longer. Definitely, I would want to see some recovery, and I would probably get a nerve study. But I think with a nerve study, then you're obligated to probably get 2 nerve studies because you want to see some recovery. So I think I would do that, but I would have no issue leaving the spacer in for longer, waiting for recovery. My experience with spacers, despite some of that data, is that patients don't like them and they don't want to leave them in. But I think here you're talking hopefully about months as opposed to years.
John, is there a level of nerve recovery where you just say you're living with your spacer?
Yeah, I mean, if they come in 3 months and their deltoid's all atrophic and it doesn't look like it's going to ever recover, then I'm gonna leave it. I mean, if I do a spacer, I do spacers a little bit different. You guys might know. I always take we call it a functional spacer, and I take a hemi-arthroplasty, meaning I take a size 6 stem and a metal ball, and I coat everything with a metal ball with antibiotic cement, and I kind of piston it before the cement hardens, so it molds to the intricacies of the humerus, and it can stay for years, 6-8 years. Probably 2/3 of my spacers never get their second stage. So in my mind, if they get a nerve injury, they just don't get function, which a lot of the patients that get revised to a spacer from a reverse never get function anyways. They don't have pain, but they're happy enough to just live with a spacer. So I think adding a true nerve injury, yeah, that's going to slow me down for sure. I think, in addition to seeing the muscle contract, I'd like to make sure that in the supine position, they can at least elevate their arm to 90 degrees and hold it there. So I want functional deltoid, not just an EMG that says the deltoid's working. I've been burned. I've done reverses when the EMG recovered after a known axillary nerve injury, after, let's say, a fracture with a malunion or something. And, you do a great reconstruction and their deltoid just wasn't ready and they don't get great function after.
Just one last question to the group. If there really is no recovery of function, would anyone do anything additional or tell the patient that they're going to live with their spacer?
Meaning, would you do like a nerve transfer or send them to Boston to do some crazy
any other
muscle transfer
treatment?
I mean, it depends. You have to feel out your patient and how old they are. I mean, this guy's a little bit older, but I mean, there are good transfers, radial nerve to axillary nerve transfers. I would consider that if they showed some interest, but they're big surgeries. They don't always do great, but it's something to consider.
All right, well, I think that wraps it up for this case. Ranjan, do we want to take questions now or it's before the next case, or?
We've covered the questions so far from the chat room, so you can move on to the next one.
Great. All right, so case number 2. So this is a 55-year-old male, past history of proximal humerus fracture 30 years ago, that he was treated with some type of percutaneous pinning and the hardware was actually removed. So no hardware is present currently. He did well after surgery, but over the last several years has had increasing pain. He's had non-operative management with cortisone injections that have lost benefit. And you can see on his exam, he has pretty restricted range of motion. His elevation is only to 80 to 90 degrees. He's got 0 degrees of external rotation. His cuff strength is good, and he's neurovascularly intact. So you can see his x-rays here of his shoulder. Adam, what do you think of these x-rays?
Pretty bad. So, I mean, obviously got a proximal humeral proximal humeral malunion. I mean, he had a surgical neck component. He had a component of his tuberosity. So I think really he's either living with this or you're considering a reverse shoulder replacement.
Yeah, so he's at the point now saying he wants surgery. What other type of diagnostic testing might you do in this case prior to surgery in terms of determining your surgical plan?
I mean, I'd get a CT scan on this guy. He's a relatively healthy guy. He doesn't have any concern for infection here.
Andy, anything else? Anything that in terms of either imaging or just things you're concerned about in terms of planning for this case?
No, I agree. I'd get a CT scan. In reality, I probably would not work him up for infection. You always have to mention that, but I probably, if I saw him in my office, would not.
Yeah, and I didn't have a concern for that either. I did get a CAT scan. It's not included in this PowerPoint, but his glenoid was basically symmetric, no abnormal of the glenoid. On the humeral side, his greater tuberosity did heal a bit posteriorly. You can see there is some mild deformity of the shaft, but it's reasonably straight. Is anyone thinking of doing anything other than a reverse shoulder replacement in this patient? No?
Nah, this is definitely a reverse for me. There's too much deformity. I don't trust the cuff, even if it is intact. But it's going to be a hard reverse. It's going to be hard to put down. There's so much sclerosis there. You have to get ready to burr it down. These are stiff and unstable all at the same time. These are hard cases in my hands.
So yeah, so I had the discussion with him, took him to surgery for a reverse. As Andy was mentioning, this guy had prior surgery as well as the malunion, so there was dense scar tissue throughout his tissue planes. His rotator cuff was intact. I did a greater tuberosity osteotomy. It had healed posteriorly, so it was affecting both putting the stem down and also just impingement. So I osteotomized his tuberosity and then repaired it at the end of the case. If you can see my PowerPoint, this is the greater tuberosity repaired here. And his post-op x-rays. You know, his stem's a little bit varus. Part of that's the malunion of the humerus. Any comments on the implant position, John?
No, not at all. I think it looks great. You know, I always worry about doing osteotomies and trying to fix them. I don't think they don't heal as well as a primary four-part fracture does, and so especially there's a lot of scar, and it was malunited posteriorly. I think trying to bring that over and get it to stay is a really tough thing. So in those cases, because I end up with a lot of proximal humeral bone loss, I feel like I end up cementing a little bit more of the malunions like this. So that would be my only concern is, you know, if you lose the tuberosity, do you have good enough fixation with an uncemented humeral component?
Yeah, good point.
Eric.
Yeah.
Yes.
You mentioned the stem being slightly invarus. Do you worry about that, and what effect does that have on your patients?
I only worry about it in terms of the way the x-ray looks. I don't think it'll have any impact on him. I mean, it's a slight varus. It's a non-weight bearing joint. I don't think I'd be concerned about it in terms of a functional or mechanical standpoint.
Gus, I just looked at this in my series of mine, and we found no differences in instability, functional outcomes, pros, nothing. The one thing we did find was, I'm just maybe not as good of a surgeon in male patients. I have more varus stems in male patients, probably because their bone is harder and it's harder to get lateral, or the exposure is not as good.
Great, thanks.
Yeah, Gus, I tell you, I don't know the last time I got a stem straight up and down. I think mine are all either in valgus or varus, especially now that I'm using a little short stem. That thing's all over the place. I think it just matters where the cup sits.
Yeah, I agree. Short, it's more, it can actually be more challenging with the short stems. I agree.
Eric,
So I was happy with this case, and yeah, go ahead.
So it looks great. The one thing that I've found in these malunion cases is I find them paradoxically spitting out anteriorly, yet impossible to reduce. So they're unstable and stiff at the same time.
Yeah.
And I never trial glenospheres ever, except in this case. And because I'll get something in, I'll put what I think I normally put in, and then I can't reduce it or whatever. And I find that in these cases for me, bigger glenospheres that are more medialized work for me. So in men, typically I use a 36 plus 6. I will often go 36, plus 2 in this, or 40 neutral in this, so I get better stability. But I trial glenospheres in these malunion cases.
Yeah, I agree. I mean, the soft tissue can almost be like a revision in that it's just not normal soft tissue tensioning. So that's a great point. So
One of the questions, hang on, Eric, one of the questions from the chat room, do you do anything different with getting the greater tuberosity to heal after osteotomy for malunion compared with acute 4-part fractures, or treat repair them exactly the same?
I personally use the same repair technique in terms of the repair. Anyone else in the group do anything different? This stem is not a stem that has suture holes on it, but I now use a stem that has suture holes along the proximal body that allow you to, repair to the implant and then also pass bone tunnels for sutures through bone tunnels. So this guy, unfortunately, post-operatively, when he came back for his post-op visit, had a diffuse brachial plexopathy, On exam, it was most pronounced in the axillary musculocutaneous and radial nerve. He basically had no deltoid function, couldn't flex his elbow, couldn't extend his wrist. So I was obviously not happy about this. With this presentation, Adam, what's your next steps when you have your patient come in at 2 weeks post-op with essentially no function?
I'm going to give it a little bit more time. I think, I mean, this guy's going to end up getting a EMG nerve conduction study, but I'd probably give him a few more weeks to see what recovery we get.
Anything you do early on in terms of trying to improve nerve recovery?
Probably not. I mean, I would have, you know, I'd have him start physical therapy. I have all my arthroplasty start physical therapy at 2 weeks, so I'd have him do that. But I don't think I would change really anything else.
John, anything you do extra in terms of medications or anything like that?
I these are the toughest patients, and I see probably 1 or 2 a year, and this is where you have to doctor more than anything else. You got to be a good doctor, so you have to give out your cell phone and tell them you've seen this before, and tell them that the chance of recovery is very high, but it's going to be a miserable 3 months of obsessing about whether this thing is going to work or not, because that's going to be all that they think about. And in the past, I would just try to say time is your only healer, but that's not enough for patients like this. They really need to know that you're actively doing something. So I tell them, listen, take B complex vitamins, and there's crappy suggested evidence that helps with nerve recovery. If you're hurting, you know, we're going to get you on Neurontin or some kind of gabapentin or something that can help with nerve pain. You know, get them to an occupational therapist where they can start to see baby step gains, because a flicker of a finger is going to be a big step for them. And you want to see them on a regular basis, and you carve out time where you can actually spend a good half hour, 45 minutes, giving them complete neurological examinations to the fine detail so that they can know that you're participating in their recovery. I will send them to a neurologist, but I don't like to do that unless I know the neurologist well, because if they do an EMG early, and they will make it seem like this nerve is never going to recover, and it could put you down a deep hole. I've actually seen cases where people got EMGs too quickly, got sent for nerve transfers, and ended up going through brachial plexus dissections and nerve transfers, and ended up much worse than they could have ever done if they had just given it time. So I think all this stuff really requires a lot of attention and doctoring, and never put your head in the sand and hope this thing just goes away. They're really very difficult times for you and the patient, but more so for the patient, and just making sure that you're there for them 100%. Just makes it a lot more easier for them to deal with. And if they have anxiety as part of their preoperative diagnosis, this is a much bigger problem.
Yeah, those are all great points, and great point about the neurologist. I mean, it's the same comment we made with the pathologist and the infectious disease doctor. It's having a neurologist that you have a good relationship with and is not going to freak the patient out. Andy, anything else you do on top of what's already been said?
I just have to reiterate what John says. I have 1 or 2 a year. I give them my cell phone number. I call them every week. And these are hard. And I would go farther to say is don't send them to anybody unless you know them, including your occupational therapist. I really actually avoid sending them to a lot of people, because it takes one comment and it changes their whole psyche. The one thing I do a little bit differently with John is, in my experience, I see nerve injuries in lots of different patients, mainly older women, but when they're younger, I think they're more likely to recover, especially if they're proximal. But when they're distal, when they're ulnar, when they're median, that's not coming back in my mind in an older woman. And I don't want to give them false expectations. I kind of break them in slowly, but I'm like, I'm not sure if this is going to recover. You're going to get a little bit more, but I don't want to over-promise what they get. And I think that's been important to me. And early recovery is great, but if you don't start seeing recovery in 6 weeks, 4 weeks, it's going to be bad.
Yeah, great points. Yeah, so interestingly, I will do a nerve medication if patients are having nerve pain. This guy, interestingly, really didn't have pain. It's just that he had no function. So I sent him for an EMG at 2 months. It was consistent with his exam, severe plexopathy involving the posterior cord and musculocutaneous nerve, but some evidence of reinnervation. And interestingly, when he came in at that visit, I had a new x-ray, which you can see here. He was showing some weak motor function return, but he had these instability complaints, particularly as he was reaching the arm out to the side. And Adam, I want to know if you could comment on the x-ray. What do you see here compared to the prior film? You see his immediate post-op and now this.
Yeah, so he's got, I mean, this is deltoid atony. He's got obviously axillary nerve involvement. So this is not all that unexpected given his kind of post-operative issues. So I don't have another view here. So it doesn't look like he's frankly dislocated. It just looks like he's down a little bit. So I'm not all that surprised.
Yeah, he's not dislocated. He was complaining to me of what sounded like potentially dislocation episodes. So I actually flowed him in the office, and as he externally rotated, he would start to come out. So I basically just told him to avoid that position until his muscles started to tighten up more. Anyone in the group do anything else at this point? Are you concerned that the subluxation is not going to go away? Would anyone add any treatment to this, John, or would you just watch this?
I just watch this. I mean, so long it's not frankly dislocating and becoming a problem for him, a subluxation or what you're seeing here, co-optation, whatever you want to call it. I think you just keep him protected and anticipate it gets better. If it's an instability problem, then now you got bigger problems. If it's truly dislocating in and out, it's going to be a harder problem to deal with. You could consider revision. You just don't want to go back on this guy until his nerves comes back.
Yeah. So oh, go ahead.
Eric has a good question from the chat room. Would anyone consider converting to a hemi to decrease tension on the plexus? Or would anyone change the polyethylene or do anything surgically to help with the nerve recovery?
I personally, because this guy is showing some early recovery, would just sit tight. That was part of what I was getting at, is if this subluxation doesn't resolve, would you try to thicken the poly? I would have concerns about going back in this early, so I personally would wait. Would anyone else consider anything?
I agree completely. I mean, I would worry more about a kind of a second hit going back early and doing something than just leaving him be.
Yeah. So you can see here this gap, and I followed this guy closely as what's already been discussed. So we discussed the subluxation. So this is actually his 3-month x-ray. So you can see that he's starting to tighten up here, and also his clinical exam is improving. And then you can see a 6-month x-ray where it's tightened up further, and his clinical exam was consistent with that. So he seemed to be recovering well over time. And I followed him out most recently to 16 months. And this is his exam at 16 months post-op. He has good motion and regained most of his active elevation, but still some residual symptoms, muscutaneous nerve sensation, and still some mild deltoid weakness. You can see on this one view that his tuberosity seemed to heal in pretty well. So I think that was important for his function. So, fortunately this one recovered. Andy, you made a good comment about age and recovery. Anything else? You talked about old age, obviously. Anything else that worries you in terms of patient factors for not being able to recover well like this guy did?
Yeah, I mean, you sort of hit on this guy sort of needs it. So like I did neuromonitoring for a while when I had my first injury in practice. I was like, I never want this to happen again. So I started doing neuromonitoring for like 50 cases. And going back to Jerry Williams and Samir Nagda's original paper, like in 2005, decreased external rotation, previous surgery, both of which this guy had, are risk factors. It was small, it was only 30 patients. And then when I started doing it, I found something similar. I found malunions have a higher rate of nerve injury, and then older women. Those are the people I really worry about. And reverses versus total. I did a neuromonitoring study where reverses, when you lengthen them, have more nerve injury than TSAs. And when you do nerve monitoring, the more you lengthen them, the more sort of subclinical alerts go off. So I worry about over lengthening.
Yeah, that's a great lead.
Andy,
Oh, go ahead, John.
no, it's a quick comment just to add to what Andy's saying, because I totally agree. I think lengthening is also proportional. So a small
Agreed.
female has a different lengthening threshold than a large male. So this is a larger male, it looks like, but the small females that are tight, fixed anterior superior scape, those are the ones I really worry about.
Agreed.
Yeah, so you guys hit all the points. I was just going to highlight, in terms of thinking about why this happened in this particular patient. Latterman and Walsh did this study on nerve lesions in both anatomic and reverse arthroplasties, and they compared them by getting pre and post-op EMGs. And as you guys already highlighted, there was a higher rate of nerve injury in the reverse group. And this wasn't overly significant, but there was some suggestion that the arm lengthening in the reverse group contributes to this higher rate of nerve injury. And if you look at this particular case, this guy did have significant lengthening when you compare the pre and post-op images, both with his pre-op images and the fact that this is a Grammont style implant. And then the nerve monitoring studies that Andy just highlighted, this guy also had some of these risk factors. In the study out of Penn by Nagda et al., they found that the combination of prior surgery and limited external rotation, not each separately, but the two together, was a significant risk factor for having more nerve alerts during surgery. And the second paper is Andy's study, where there was a higher rate of nerve alert, particularly during post-reduction in the reverse group. And you see these associations with decreased active forward elevation and cuff tear arthropathy being associated with nerve alerts. And, when you look at both these studies, interestingly, although patients have a significant number of nerve alerts, the majority of these cases, when you look at both studies, recover their nerve function. A small number have abnormal EMGs postoperatively or true clinical signs, but essentially almost all of them recover by 6 months. So just to end this case, I'm going to do the twist to it again. So, this case was a nerve injury. So if we twist it and add an infection, what if we have the same patient and he's got this subluxated reverse that you can see here in the early postoperative period, but he also walks into your clinic at 2 or 3 weeks post-op with wound drainage and an acute PJI. So he's got his plexopathy with this subluxated joint and an acute PJI. And I'll pose the same question as I did in the first case. How does this change your management? And in particular, you have to address this PJI. How is that going to change what you do in terms of the approach to the PJI? John, why don't you start?
So I'd say, it's infected. So you're in damage control that goes well beyond the initial nerve injury. So you got to treat it. You can't put your head in the sand. So you've got to go and take this patient back. And if it's an acute, you can potentially do just modular component exchange and hope you can beat it with just a debridement. But if this is, 4 or 5 months in and now he's presenting with a draining sinus, gosh, you got to take it out. And maybe now he gets his hemi. But I think if I'm reviving this, I'm not doing a single stage revision or reverse when he's got an actual nerve palsy. I'm going to take it out and put in a hemi.
So the question was brought up before about, upsizing the poly. Adam, if you really were treating this as an acute infection where you're maybe just going in to do a washout and maybe a modular component exchange, because this guy's subluxated, would you try to tighten him up? Would you actually try to maybe upsize the glenosphere or the polyliner?
Without a nerve injury?
If he has this nerve injury and you're going in to wash out an acute PJI, so you have both.
Yeah, I mean, with this nerve injury, I would probably put a hemi in. Honestly, I don't think I would try to
You'd put a hemi in for an acute PJI?
I would put a hemi spacer in. I think in this guy, I would take it out and do that. I worry a little bit. I mean, we just talked about arm lengthening, and if you start, you're infected and you're trying to just exchange the modular components and you start lengthening the arm more by adding polyethylene, I just worry a little bit about that. I think I would have a pretty low threshold to take everything out, put a hemi in, and adequately treat the infection and not have to worry about his continued instability.
So instead of trying to tighten up the subluxation and potentially worsen the nerve injury, the idea is to revise to a hemi to take tension off the nerve.
That's correct.
Yeah. Andy, anything different?
No, I'd probably vomit first, and then I would I would actually probably do a modular exchange, try and minimize going. I'd go in, wash it out, try and be minimal. What I found when I go back in revisions in reverses, they're always loose. You always have to go up a little bit just to get back to baseline. So I think I probably would do modular exchange and make it, probably put in a bigger poly or bigger glenosphere just to make it stable.
All right. Do we have time for one more case, or do we want to just try to take some questions?
I think you can go through quickly the next case. Okay, we've gotten the questions through.
All right, so we'll go through this one quickly and keep it more straightforward. So this is a 51-year-old male, former bodybuilder, had a hemi resurfacing done 3 years ago. He wanted to keep competing. He did well initially, but has developed worsening pain over the last 6 months, is no longer able to compete and lift. On exam, he's got limited motion, but good cuff strength, negative belly press test, neurovascularly intact. You can see on his plain radiographs the resurfacing. My concern in this case was that it was placed overstuffed. If you look at sort of I'm going to draw the arrow, the circle fit of the proximal humerus, this implant seems to be put in a little proud where it looks like they resected the humeral head to cause that. And there's some concern on his glenoid of some arthrosis to the glenoid. Which on CAT scan, you could see that. I don't have it in the case, but you can see it. In terms of his preoperative workup, just to move through it quickly, I typically will work people up for infection, even in the setting of an indication for an aseptic revision because of the prevalence of C. acnes. So I got an ESR CRP on this patient. It was normal. His aspirate was normal. The CT, I got an arthrogram to make sure his subscap was intact, which it was, but again, it showed glenoid arthrosis. So if this patient is ready to have a revision surgery, Andy, what's your approach in this case if you're going to revise this guy?
Yeah, so I would actually talk to this guy about, I agree, CRP, sed-rate, I do an aspiration. I would talk to him about both a total and a reverse. In my opinion, the subscap is not always great in these cases. I know he's young, but he's already failed one. So if his subscap was great, I would consider a total. If it wasn't, I would do a reverse. I would take 5 samples at the time of surgery. If I was concerned, I would discuss with him a Prostilac. If I wasn't concerned, I would go on with the surgery. I think frozen section it would help my decision as well. And keeping on PO antibiotics until we got culture results. If they're positive, do IV antibiotics. If they're negative, take them off after 14 days of POs.
Hey, Andy, it's Bill. Can I push you on that a little bit?
Yep.
So I get it, and academically and for the fellows, that's great to say that we should rule out an infection. This is a surgical error. He has no signs of infection, and he's got a painful shoulder. So I think it's great that Eric did all those things, but this is a surgical error. It's an overstuffed shoulder. It's not infected, most likely. And of course you can drive yourself crazy with then getting, partial results on aspirations and all that stuff. So if it looks like a duck and it smells like a duck and it tastes like a duck, then order the duck.
I think that's very
well, actually, so
I
a follow-up to Bill's point, John and Adam, would you take cultures in this case?
So I would, if intraoperatively he had tons of scar, so that sort of intraoperative scar feeling, that yeah, I would take cultures. I would do this as a single stage, so he's still getting his. I would do his anatomic here. I would, I think you could do a nice anatomic neck resection, get that implant out pretty easily. I think you can do a standard total shoulder without a problem. You might need some additional releases. If I take cultures, I put him on IV antibiotics for 2 weeks. If the cultures are negative, he's done. If they're positive, he goes on for a 6-week period of IV antibiotics. And I've done a single stage better than a typical signal stage where you're taking out implants on both sides, because this one comes out pretty easy.
Agreed.
Yeah, I'm the same. I mean, I in any revision, I'm taking cultures, even though I agree completely this is a biomechanical problem, but I'm taking cultures. I'm treating with oral antibiotics for 2 weeks and waiting to see what those cultures show.
But if I can make one point, is if you don't even talk about a prostalax and you go in there and you find pus, yeah, maybe you could do a single stage revision and just do it. But you're going to be in the situation where you didn't discuss with this patient what you're going to do, and you're making this intraoperative decision. I think that's bad practice. I think you need to spend the time and go through the scenarios. Even though you don't think this is going to happen, you have to let them know in any revision, these are all the possibilities.
And Andy, I totally agree. I'm not saying to not, I'm just saying that, you know, there are those cases where you are comfortable as a doctor first and surgeon second saying, this is a mechanical problem. There's always a chance of infection, but we think that by simply, you know, putting in a prosthesis that's better fit with your anatomy, et cetera, that will take away your pain and get you back on track. But that was my own.
Fully. Yeah, totally agree.
So I agree with all the points that were made. I took him for revision. His subscap was fine. Same decision making, it's been discussed. I revised him to an anatomic because he had a good subscap. His implant was well fixed, and you know, he had this, if you can see my arrow, he had this unresected humeral head, so there was still some osteophyte present. And I've found in these revisions with resurfacings, you get sort of this sclerosis here. It can be sometimes hard to identify where the true tuberosity starts, and you can make the error of still under resecting. So sometimes in these cases, I'll get fluoro to make sure I'm truly getting the neck shaft angle so that I end up putting my revised implant in anatomically. His frozen sections were negative, no purulence. So I revised him to a 1-stage anatomic. You can see it here. So post-operatively, I took 5 tissue cultures, or maybe, and post-op day 2, he has 1 out of 5 gross staph leukadhesis.
I told you.
So would anyone, and I put people on, you know, 2 weeks of PO doxy as well. So this patient's on PO doxy for 2 weeks. Would anyone treat this or do anything different?
No.
Okay, so then
That's a UPC, brother.
So then same day he has another 1 out of 5 of staph epi. Would anyone treat that? No. So I didn't treat these,
2.
and then
now you got 4 points.
And then, so then now post-op day 6, 4 out of 5 cultures grow C. acnes.
There you go.
So
You're right, Bill.
He gets 6 weeks of IV antibiotics, and he feels better about it, and he did a 1-stage reimplantation. He's going to do great.
Yeah, so I didn't treat the first 2 cultures. I treated the C. acnes. If I get that many cultures from the same organism, I treat it. I do 6 weeks like John suggested, and then a period of POs. But I bring this case up, you know, does this group really think this is a periprosthetic joint infection? Is this a PGI, or is this a revision with positive cultures? Adam, what do you think? Would you call this a PGI?
I mean, this is a revision with positive cultures, but I think you're obligated to treat it at this point, like you did.
Remember, you don't know if this infection occurred during your dissection.
Yeah.
But Eric, according to your Delphi process, this would be a PGI, right?
Well, that's a great lead-in. So if you actually, so I treated him with 6 weeks of IV antibiotics and then a period of orals. He did very well. You can see his function at 1 year was great. And if you actually, you know, put this case into the scoring system, he essentially had nothing that would give him points other than the cultures, and the scoring system only gives you points for 2 positive cultures. So you don't keep getting points for additional positive cultures. So his score is actually 4. You'd call it a possible PGI. So I think in this case, it's appropriate where you have these positive cultures, but no other clear reason that you would say it's infected. So the scoring system actually, I think, does a good job of kind of describing these cases where we're not really sure what they mean. Any other parting thoughts?
Great job, guys. That was
Great job.
Unbelievable. Thank you very
Good job,
much.
everyone.
Really
Great pearls.
terrific. Yeah, terrific pearls and terrific cases. And Eric, way to put the spin on all of them.
Yeah, thanks.
We
Thanks.
appreciate,
Hopefully we don't have to deal with double complication very often.
All right.
Thanks.
Good night,
Thanks,
everybody.
guys.
Good night, everybody.
Night.
Thank you so
Thanks,
much.
guys.
Appreciate
Thank you,
it.
guys.
Thanks, guys.
Thank you.